I would like to introduce today's speakers, for it's not just the shakes. Tremor and motor systems are often the most obvious signs of Parkinson's disease, but many people find that so-called non-motor symptoms can be equally or even more problematic. In this session, Dr. Avrom Kurtz will be discussing a number of the cognitive and neuropsychiatric symptoms that can arise in Parkinson's disease, including depression, anxiety, and changes in thinking and memory. Dr. Aaron Haug will be discussing a number of other non-motor symptoms that people with Parkinson's disease may experience, including autonomic symptoms, constipation, overactive bladder, changes in sexual function, and orthostatic hypotension, sleep problems, and sensory problems, including pain. Please help me welcome these two doctors.
Thanks everybody for coming out. I appreciate you taking the time to come here, and hopefully you'll be able to learn something from the talk today. And also thanks to the Parkinson's Association for running this great session. So what I was asked to talk about was things that are not related to the typical symptoms that we think about with Parkinson's, the visible symptoms where we see people shaking, having tremors, having stiffness, having slowness. These are the things that are really behind the scenes. These are things that you can't look at somebody and see that they're having these types of symptoms. These are things that are what we call non-motor symptoms. These are very common, and that it really affects almost every person who has Parkinson's disease. A lot of times these symptoms actually happen before the shakes happen, before the slowness, before the balance problems happen with Parkinson's disease. And oftentimes these are more disabling than the other symptoms that we're dealing with Parkinson's disease. The most important thing and the main reason for having this talk is that this is often under-addressed with physicians, that patients don't often feel open to talk about these issues, or physicians don't have the time to talk about this. So I want to really show you a lot of different things that you can maybe identify that you can bring up with your physician the next time that you're working with them. So I was going to talk about a small subgroup of the non-motor symptoms. These are just some of the different symptoms that people with Parkinson's can have. A lot of these Dr. Haug will be talking about in the next section, but I was asked to talk more specifically about the neuropsychiatric problems that go along with Parkinson's disease. And some of these are related to medications. The medications that we're intending to help improve symptoms of Parkinson's disease can have side effects, and so some of these are actually side effect related. Some of these are progressive disorders such as memory problems, and also anxiety and depression are very big topics to discuss. When we talk about things that are caused by the medications that we're using for Parkinson's disease, we need to think about impulse control problems, we need to think about dopamine dysregulation, and people who have hallucinations and other problems related to the medicines. Impulse control problems are things where patients or people are having these experiences where they're doing something that's very enjoyable to them, that they enjoy doing these things, but they're doing this at a cost, that it's hurting themselves, that it's hurting family members, that it's taking away time from meaningful things, and can be caused by medications. We typically think of the medications ropinirole or pramipexole as being very common medications that can be caused by this, but we do also see this with Sinemet, the carbidopa, levodopa, and there have been cases reported after people have had DBS, and I've seen that in some patients where they do become impulsive after having brain surgery for Parkinson's disease. So impulse control behaviors, the things that people are doing. In one study it showed that compulsive shopping was very common, and almost 5% of people started to shop even though they weren't intending to buy extra things at the store. They end up coming home with a lot of extra things. Pathological gambling, which I'll talk more about in a second. People can become hypersexual because of the medications and have a very high sex drive, and also that they can have difficulty with controlling their appetite, that they're going to start binge eating and eating excessively. So pathological gambling is something that's very important because this can have a really detrimental effect on the family if somebody's obsessively going to spend their finances, wager their house on gambling things. And this is something where patients often don't really realize that they're doing this. They become very deceitful, they become manipulative with their money, and they end up spending a lot of excess things with gambling. It's important to realize that this is a risk factor just by having Parkinson's disease. So in the general population, we think about 1% of the population is at risk of becoming a pathological gambler. If you have Parkinson's disease, then it increases to about 4 or 5%. And then if you have Parkinson's disease and you're on some of those medications for Parkinson's disease, it can increase to as high as 8%. So this is something that can happen quite commonly. When this happens, it can occur even with very low doses of medications, so it can be a starter dose of a medication that can trigger this. We more often see it in higher doses of the medication, but anybody starting these medications should know that this is a possible consequence or a possible side effect to the medication. We typically think that people who are younger, when they get diagnosed with Parkinson's and start on these medications, are going to be at much higher risk for this. We think that people who've used abused substances in the past, or those people who like to bungee jump or do thrill-seeking activities, they have a much higher tendency of becoming gamblers as well. There's a lot of things that you can do if this happens. First of all, lowering the dose of medication that patients are on or taking the medications away entirely tends to help the symptoms quite dramatically. Also, making sure that the finances are secured and that the person who is gambling is not having access to the money so that the money's not wasted. And there are organizations like Gamblers Anonymous that has been shown to be helpful. And also there are psychotherapists who work specifically on cognitive behavioral therapy, which teaches patients to understand the consequences of their action and can refocus their attention and help with their symptoms. Another activity that we see typically with Parkinson's disease and specifically related to medication is called Punding. This is where people start to do a very stereotypical activity, that they start to do things very obsessively, and they're doing things repetitively over and over again. They start collecting things, they start to sort things very carefully, they start to assemble things and then disassemble it and then assemble it again, and they spend excessive time doing these things, and again at the harm of their family because they're doing these things and taking away time from their family or away from their friends. It typically is something where we see men doing things related to pastimes or other interests that they have. Same thing with women. A lot of times you'll see men taking apart an engine, then putting it back together again, or organizing shoes, or other things can be seen with this. So this is more common than pathological gambling, and it can happen in almost 14% of people. So this is something that is out there and does happen. This again is most commonly caused by those dopamine agonists, the pramipexole and ropinirole are most common, but again you can see this with the carbidopa-levodopa. And again, these are something where oftentimes the individual can identify that they have this problem, that they know that they're going to do this, but they often have a hard time stopping themselves from doing these activities. So very similar to the pathological gambling, the main thing is to take people off the medications that could be inducing these behaviors. There's a couple of other things that have been shown to help. There's another medication called amantadine that we use for Parkinson's disease. That has been shown to be helpful for this type of activity. Medications that slow down, that are considered to be antipsychotic medications have also been shown to be helpful. And then sometimes medications like donepezil or antidepressants can help as well. There's another condition, and the last condition that I'll talk to regarding medication-induced side effects, and this is called dopamine dysregulation syndrome. And this is a condition where the medications become desired by patients. So they're not just taking the medication so that they can walk better or they can relieve that tremor that's bothering them. They're actually craving to take the medications, very similar to using substances of abuse. They have a withdrawal. They notice when they're off the medications, they want more. They're going to take more than is typically prescribed from them by the physician, and this does happen in about 4% of people with who are on dopamine agonists associated with, or carbidopa-levodopa associated with their Parkinson's. To shift gears a little bit beyond what medications can cause, I wanted to talk about psychosis. And this is a very common thing. Again, this is something that can be induced by medications, and I'll touch on that a little bit, but it can also occur separately. This is a bigger problem than the other things that I was talking about, because this can happen in about 50% of the population with Parkinson's disease. And psychosis is something where people have delusions, they have false beliefs, they have hallucinations. All of these things can occur and often are worsened by medications. So when somebody has hallucinations, which again is typically exacerbated by medications in Parkinson's disease, they're typically visual hallucinations. It's very rare for somebody to have an audio, a hearing type of hallucination. They typically see things. And for some reason, people have a tendency to see animals. They tend to see little kids running around. Sometimes the figures are miniature, sometimes they're full-sized. The images can be moving around, they can be stationary, but often they don't respond to people. So they tend not to converse. People don't end up hearing what they're saying, but they can see them and they can be quite real. Hallucinations do tend to happen more in people who have depression, which is important because depression is something that can be treated, and if the depression is treated, then the hallucinations may be better. The other thing to realize is that hallucinations are often caused in people who have visual problems. So vision has a large effect on predisposing people to hallucinations. So people who have cataracts, people who have retinal problems, they're going to have a much higher tendency to have hallucinations. So certainly working with an eye doctor, optimizing your vision as best as possible is going to help to minimize hallucinations. So that's a very important thing to think about. Besides hallucinations, as part of psychosis, one of the things we think about with Parkinson's disease is delusions. So having false beliefs, believing things that aren't true. So there's a couple of names that we've given to some of these syndromes. Othello Syndrome is where you think that your spouse is having an affair, and this can cause a lot of conflict in a relationship. The other syndrome is called Capgras Syndrome, where you believe that your significant other or people in your house are actually imposters. And then a phantom boarder is that you believe that there are people who are actually living in your house and staying in your house, even though that's not the case. I had a patient recently who was actually setting up a table, waiting for one of their hallucinations to sit down and join them for a meal. So these things can be very real and very persistent. So the most important thing is not to be scared that hallucinations are something that can happen or delusions can happen, but to understand that there are things that can be done about it. So most importantly is finding medications that could make hallucinations occur or could exacerbate hallucinations. So there's a number of medications that are very common, especially in the elderly population, that we use for spastic bladders or urinary problems. So making sure that you're not on those medications that I listed up there. Certainly a lot of the Parkinson's medications can make delusions occur, can make hallucinations happening. So taking away amantadine or a dopamine agonist or carbidopa levodopa can often help to relieve the hallucinations. There's a number of anticholinergic medications like Benadryl that also can have an effect on thinking, and that can also result in people having hallucinations. There's a list of medications in your handout at the bottom, which are typically medications that an ER physician or other doctors would think about to prescribe in people who are having hallucinations or delusions. But I just wanted to put that list out there because those can be very harmful for Parkinson's patients. They can cause a lot of side effects. They can make the Parkinson motor symptoms a lot worse. So those are medications to avoid in case this is occurring. Other medications that we can use, however, that are good and helpful are medications which we call cholinesterase inhibitors. So Aricept has been a long-used medication for memory problems, both in Parkinson's disease as well as in Alzheimer's disease. This has a tremendous effect on delusions and hallucinations. Rivastigmine or Exelon is also a very helpful medication for decreasing the frequency of hallucinations. A medication called quetiapine or Seroquel can also help lower the chances of hallucinations, and then Clozapine can also be helpful. Clozapine has been studied. It's been shown to be effective in Parkinson's disease to help with hallucinations and delusions, but it is a very complicated medication to use because patients have to have blood draws once a week, and so it's not a very easy medication to administer, but for people who are having a lot of difficulty controlling hallucinations, this can be a very effective medication for them. There's a new medication worth mentioning as well. This is currently experimental, but the drug company is seeking a fast approval through the FDA to try to get it out onto the market. And it's been shown in one study to be very effective at helping with hallucinations. And this medication works a little bit different than the other medications that we typically use. And most importantly, caregivers said, the people who were on this medication, they did a lot better, much less burden on the caregivers. They felt like the patients were much more alert during the daytime. They had improved sleep. So hopefully this medication will be on the market in not too long of a time. To talk about memory problems in Parkinson's disease, to shift gears, this is a complicated thing and certainly something that I could spend hours talking about, but I just wanted to give you an overview about the different ways that we categorize memory problems and also to talk about the different things that we can do about memory problems. So we have listed a couple of ways of categorizing memory problems that we see in Parkinson's disease. We think about people who have absolutely no memory problems, which is very common, in that we say that they're cognitively normal in Parkinson's disease. You can do formal neuropsychiatric testing. There's no signs of deficits. They function very well, so those are cognitively normal. And then we have variations of memory problems, starting with mild cognitive impairment, Parkinson's disease, dementia, and Lewy body dementia, or dementia with Lewy bodies, which I'll explain the difference between in just a second. So when we talk about mild cognitive impairment in Parkinson's disease, this is something which is actually very common, even very early on in Parkinson's disease. We can see it in as much as 20 to 40% of people who are first diagnosed with Parkinson's. If you do formal and enough memory testing, there will be some signs of memory deficits and some memory decline even in the early stages. This is something where patients will notice that they have a little bit of limitations with their memory, but they can still do everything. They can be interactive, they can still drive, they can meet with their friends and be social. It does not really impair their quality of life. When we're looking at how we test memory problems, there's a lot of different ways that this can be done. Most important for me is talking with patients and the caregivers, finding out what the complaints are at home, how are things at home, does the person remember to take their medications, are they forgetful with their appointments, do they have difficulty remembering these things. In the clinic, we can do a 5-minute test, which is called a mini mental status or a Montreal Cognitive Assessment Score. Both of those give us some measure of memory problems and also allows us to follow memory problems over time. And more thoroughly is a neuropsychologist who can do a formal neuropsychiatric testing to really find the finer points of memory deficits if there's any concerns about that. With mild cognitive impairment, we typically see that there's some problems with coming up with words, that there's some slowness in thinking. If somebody's asked a question, they take a little bit longer to process that information before they're able to give a response, that they have difficulty learning and retrieving information as well. One of my mentors, Dr. Troster, who's done a lot of research in memory problems, explained memory problems with Parkinson's disease as a file cabinet. And he described how everybody has a file cabinet with all their information in their head about all the things that are going on, about who their friends are, everything else. And so it's just like a file cabinet that keeps your bills. So you have a file for mortgage statements, you have a file for your gas bill, you have a file for your phone bill. All of these files are nicely organized, alphabetical. So if you want to know how much your mortgage payment is, you can find that very quickly. In Alzheimer's disease, somebody's gone into your file cabinet and taking out those files, they've put them in the shredder, you're not going to find those files anymore. They're completely gone. You're not able to access those information, so you'll never be able to find your mortgage statement. You're not going to be able to find those important things that you're looking for. In Parkinson's disease, it's important to realize that this is a completely different type of memory problem. All of those files are still there, but somebody's gone in there and they've mixed them up. So you look for your mortgage statement, it's not in the folder that it should be in, but then you have to look around, oh, somebody put it in the phone bill, so that's where your mortgage statement is. So you can find that information, but it certainly takes a lot longer to be able to sort out where that information is. Beyond mild cognitive impairment, we start to deal with dementia. And so with dementia, this is a progression of the memory problems, and this is a memory problem that ends up causing significant disability for people because they're not able to remember appointments. They forget their medications. They become more reliant on caregivers. And this can occur in a lot of patients who have Parkinson's disease. There's a couple different ways that we've labeled the types of dementia that occur in Parkinson's disease. And it's not necessarily important to understand that there's two different types of dementia, because I think people get hung up on, oh, is this Lewy body dementia or is this Parkinson's disease dementia? Because the symptoms are very similar and they're treated very similar as well. We typically want to make the categorization based on time. And so if somebody has early memory problems, or if they start to go see a memory specialist before they see a movement disorder neurologist, then we typically would see that they have Lewy body dementia or dementia with Lewy bodies. And if they have Parkinson's symptoms, if they have tremor, and then only 10 years, 12 years later, do they start to develop the memory problems, then we call it Parkinson's disease dementia. So artificially, we've labeled Lewy body dementia as having symptoms of Parkinson's disease and then memory problems within 1 year. Anywhere after a year, we typically label as Parkinson's disease dementia, but they're very similar conditions and again, very similar treatments. So what do we do for treating these types of symptoms? So we first look for reversible things. We think about exercise, we think about mental activity, and then medications. So there's a couple of things that are always really high on the list for thinking about things that can cause memory problems. Depression is really at the top of the list as something that can mimic memory problems. So depression is a treatable thing that can cause memory deficits, and so that needs to be treated if there's any depression involved. Obstructive sleep apnea is a condition where people have difficulty with breathing at night, that they have very loud snoring, they're not exchanging oxygen very well, they're depriving their body of a lot of oxygen that they need, they're going to feel tired, they're going to feel sluggish the next day, and certainly that's going to affect their memories. And some studies have shown that by treating it with a CPAP machine, which this gentleman's wearing, can be very helpful at improving memory as well as quality of life. And avoid harmful medications as well is always important. Very similar list to the medications I was mentioning before. With psychosis is the anticholinergic medications like Benadryl and the urinary medications, but certainly narcotic medications can do that. So if people are having back pain and are on Percocet, that's going to affect their memories as well. And then anxiety medicines like Valium can also do that. This wouldn't be a Parkinson's talk without throwing exercise in here somewhere, and so we do not have as much information that we'd like to have about how much exercise can help with cognition, but certainly there are some small studies that indicate that the more people are active, the more people are exercising, the better it's going to be for preventing memory progression over time. There's also been studies to look at whether or not working with a cognitive therapist, working on your reaction time, working on your speed of thinking to see whether or not that's helpful. And so patients were allocated to do 20 hours of memory tasks. Then every week they did 3 hours kind of as follow-up sessions. And they had improvements in their memory after 3 months, that they were able to visually recall things better, that their attention span was better. So significant improvement by putting in the effort towards improving their thinking. Cholinesterase inhibitors are medications which have been used a long time for Alzheimer's disease, but we also use them for Parkinson's disease because they can be very helpful. I already mentioned that they can be helpful in controlling the symptoms of psychosis, but we do think they could slow down or at least stabilize memory problems associated with Parkinson's disease. And there's a couple ones that are used. Rivastigmine or Exelon has been approved by the FDA, but many people use Aricept as an alternative, and it works very well also. There was one study that showed the benefits of rivastigmine in patients being tested with memory tests, and the group on the top are the ones who were taking the medication, and the group on the bottom are the ones who were not taking it. So the people had improvements in their memory, and it sustained itself compared to not being on that medication. Memantine is another medication which we do use for memory problems. In my experience, it tends to be most helpful for people who have psychosis, who have fluctuations, who have agitation associated with their memory problems, much more so than just a memory medication, but it is something that can be used as well. To talk about a couple more neuropsychiatric symptoms, anxiety and depression are very important things to discuss. There was a very large study that was completed in 2009 that had over 5,000 patients, and they had large questionnaires, and they were asked, what are the things that bother you with Parkinson's disease? Is it the tremors? Is it your loss of mobility? Is it the slowness? What is it that bothers you? And anxiety and depression were the top of the list. So over 5,000 people said, these are the things that really influence my quality of life. These are the biggest issues that we need to address. So we found out actually that it was twice as much of a burden for patients to have depression or anxiety than it was to have tremors or slowness or the other things that we consider to be movement disorder, motor symptoms. So when we talk about anxiety, this is a very common thing. It can happen in about 40% of people with Parkinson's disease. This can happen as panic attacks where things are going just fine and all of a sudden it hits you where you start to freeze, you start to get short of breath, you become very clammy and very anxious. Otherwise, you can just cause a little bit of generalized anxiety as well, and this can have a big effect on quality of life. It may prevent you from going out to lunch with friends. It may prevent you from being able to do things that are important to you. This is very commonly associated with Parkinson's medications as well, that we tend to see that as the medications are working, much less anxiety, and as the medications are wearing off, anxiety can start to occur. And the reason that's important is that by adjusting some of the Parkinson's medication, make sure that you're on an adequate dose and that your dose is well maintained over time, you can prevent some of that anxiety. It's very common for people as their dose is wearing off to feel their chest is tightening, that they feel short of breath, that they're clammy, that they're wearing off, and that can feel much like anxiety. So treating those things with medications for Parkinson's can be very helpful. If the anxiety is very mild, psychotherapy can be very helpful. Working with cognitive behavioral therapists does seem to help with anxiety. And if it's more severe, then starting on an antidepressant medication can be helpful, or using benzodiazepines like Valium to help in situations. Depression is also very common in Parkinson's disease. Some studies estimate 30 to 40%. To me, that seems a little low, and I think that it's probably a little bit higher than that, but that's kind of the studies showing the incidence of it. Again, it happens typically more often in females than in males. It does seem to happen more as the disease progresses with Parkinson's disease. The most important thing to realize about both anxiety as well as depression is that this is a chemical imbalance in the body. I think we're still at a phase where people think that it's a character thing or that it's part of their personality or something else like this. And we need to understand that it's much more than this. This is a chemical problem. This is a graph that shows the levels of chemicals in the brain, and we all know that Parkinson's disease is a loss of dopamine, and so you'll see on the graph that the dopamine levels are significantly lower than everything else. But the NA and the 5-HT are both chemicals which help us to feel good. And so the levels of those in a typical person with Parkinson's disease are about 50% of the general population. That's going to predispose people to anxiety, predispose them to depression. And so people have to understand that this is a chemical problem and that it's okay to ask for help if that is an issue for people. So what we see with depression, it does cause a lot of problems. As I mentioned earlier, depression does have a profound effect on memory, so that needs to be corrected so that the memory impairments are not affected. That we tend to see that if there's a lot of depression, we're going to see that the disease is progressing quicker. And again, this is another thing which is under-recognized by physicians, that we don't identify enough people who have this. We don't openly talk about it with people as much as we should be doing. There was one study that showed that of all Parkinson's patients, only about 20 to 25% are on an antidepressant. And so I already said that the rate for Parkinson's is about 40% or so. So we should expect that about 40% are on medications or working towards getting treatment for it. So certainly under-recognized. We also found in studies that we typically don't treat Parkinson's patients aggressively enough with antidepressants. We typically will try one medication, say, oh, it didn't work, okay, let's move on and not try other medications, because everybody responds differently to medication, so if there's still depression, other medications should be tried. Also, we found out that the dose range is also typically low in Parkinson's disease, and that should be adjusted. Here's a few things that we can do to help with depression and anxiety. Certainly exercise has been shown in a lot of studies to elevate mood, to bring you in social contacts and to be better for you. Some of the studies have also shown just social interactions can be helpful for depression. Psychotherapy is certainly something that's helpful. For those who have really refractory depression and have been on multiple medications, have been working with a psychiatrist who have not been able to control their depression, electroconvulsive therapy has been used, and it's actually been shown to be fairly safe in Parkinson's disease. There's a number of medications which we typically think about for Parkinson's disease. These run in a couple different classes. The typical medications are listed here, and I don't have time to go through all of them, but it's important that the medications have good side effects and bad side effects. And so oftentimes when you're choosing an antidepressant for somebody, if they have a side effect that could actually benefit you, then you may want to be on those medications. So for instance, sertraline tends to have it causes people to have a dry mouth. And so with Parkinson's disease, oftentimes we'll see excessive drooling. And so choosing that medication might be helpful to help both depression, also to clear up the saliva in the mouth a little bit. So you can fine-tune what kind of antidepressant you use based on how the benefits are going to work for you. Another example of that is venlafaxine. So another problem that we deal with Parkinson's disease is drops in blood pressure and low blood pressure, which causes dizziness when you're standing. And so venlafaxine is an antidepressant which has actually been shown to elevate blood pressure. So in that population, it may be a good medication for some to be on, as it does boost up the blood pressure a little bit and seems to help. To finish off, I just wanted to talk about transcranial magnetic stimulation. Again, this is an experimental treatment for depression in Parkinson's disease. And actually, Benzie Kluger is doing a study right now looking at transcranial magnetic stimulation on memory deficits in Parkinson's disease at the university. So that's something where we're learning a lot more about. This has been a treatment that has been used for depression for a number of years, and we have very small studies that show some benefit in Parkinson's disease, but again, we need to find out more to see whether or not we can actually bring this into play, both for the cognitive deficits as well as for the mood disorders that happen with this. So I was going to pass on the mic to Dr. Haug, who's going to talk to you about the other the other non-motor symptoms associated with Parkinson's disease, and then at the end I'll be around for questions if needed.
So thank you, Avi, for that excellent covering of the many and complicated neuropsychiatric and behavioral symptoms that can arise in Parkinson's disease. Again, I'm Aaron Haug, a neurologist down in Inglewood with specialization in movement disorders. And I'm going to be talking about some of the other non-motor symptoms in Parkinson's disease. And these roughly fit into these categories that are listed here. Autonomic symptoms, which I'll talk about what that means, pain, sleep, and then other symptoms. So it's getting towards the end of baseball season here, and here's a famous baseball player, Yogi Berra, and he said once that it's tough to make predictions, especially about the future. And the reason that it's important to make a comment like that is that as we go through both the symptoms that Dr. Kurtz discussed as well as what I'll be discussing, it's important to know that not everyone is going to have all of these symptoms. It's not a checklist of things to look for or to worry about as time goes along. Not all symptoms need to be treated. If you were to take all of the medicines that Dr. Kurtz and I mentioned in these 2 talks, then you would be on more medicines than you already are. The reason that it's important to talk about these is to increase awareness, both by patients and their families and their caregivers, because if these are under-recognized, then becoming aware of them and exploring the treatment options can lead to an improvement in quality of life. So autonomic symptoms refers to function of the gastrointestinal tract, as well as the urinary system, sexual function, and blood pressure. So when you think about the autonomic nervous system, think about things that happen automatically. So we aren't consciously in control of how our gut moves or when exactly we have to go to the bathroom, or certainly not what our blood pressure is. So these are all parts of the body that are controlled by more automatic functions. There are a number of gastrointestinal symptoms that can arise in Parkinson's disease, and these include constipation, nausea, drooling, and swallowing difficulty. I'll talk a little about each of these. Constipation is probably one of the most common non-motor symptoms in Parkinson's disease. If I have a patient who says that they never have any trouble with constipation, then I think that they're maybe just not actually telling me about their problem with constipation. So treatment for constipation falls into a wide range of options. Some of the places to start are ensuring good hydration, exercising regularly. Something that I'll talk a little bit more about in another slide or two is sugar-free gum. The sweetness in a sugar-free gum often comes from a sugar alcohol like sorbitol, and so this is something that can actually help with constipation as well. Other treatments can include fiber. A good way to increase fiber intake is through breakfast cereals, where you can sometimes find something that tastes better than the box that it comes in. Fruits, especially prunes, and vegetables are other good ways to increase fiber intake. Bulking agents, particularly Metamucil or psyllium, can be helpful for constipation. And then another fairly conservative treatment that's available as a medicine is a stool softener, and this is docosate or Colace, which can be taken even on an everyday basis to reduce constipation. Other more aggressive treatments include laxatives, such as polyethylene glycol, which is best known as Miralax, as well as Senna, which is available either as a pill but also in tea form. And laxatives can be very effective but need to be used with some caution because they can cause a dependency where the bowel will sort of fall asleep without stimulation by laxatives. Other medicines that can be helpful include pyridostigmine, which is Mestinon, which I'll talk more about for another non-motor condition as well. A newer medicine called lubiprostone or Amitiza, which is approved for idiopathic constipation, has also been shown to be helpful in Parkinson's disease. And then sometimes suppositories and enemas can be helpful when necessary. Now, nausea in Parkinson's disease, like Dr. Kurtz was talking about, can either be something that's a side effect of medicine or that can occur as part of the condition itself. So treatment of nausea can include medicines such as Zofran or additional carbidopa, which is half of Sinemet, is available as a standalone pill called carbidopa or Lodocin, and when taken with each dose of Sinemet can help lessen Sinemet-induced nausea. There's also a medication called domperidone, and while this is not approved by the FDA in this country, it can be obtained through compounding pharmacies and can also be very helpful in the treatment of nausea. Again, as Dr. Kurtz mentioned, there are some medicines that should be avoided when considering now nausea in the treatment of people with Parkinson's. These are medicines such as Reglan, Compazine, or Phenergan, and the reason that these should be avoided is that the way that they work is by blocking dopamine. And of course, that's counterproductive when we're also giving dopamine pills to try to help with the physical symptoms of Parkinson's. Drooling in Parkinson's disease is a somewhat misunderstood issue. Some people think that there's actually an increase in saliva production, but it's probably more so the case that there's a decrease in how often a person is swallowing, and that leads to an increased pooling of saliva, which can then lead to drooling. So treatment can include some things that will increase how often a person swallows spontaneously. And this again can be sugar-free gum or sugar-free hard candy. because by increasing saliva and just having something in your mouth, you'll swallow more often. Although saliva excess is not the problem, a lot of the medicines that we use to treat drooling work by decreasing saliva production. And so this includes tablets such as Robenal, which is glycopyrrolate. One trick that we sometimes use is to use atropine eye drops, which are actually for glaucoma, and putting those underneath the tongue, and that can help dry out the mouth for a period of several hours. More invasively, but sometimes more effectively, can be botulinum toxin injections. Yes, this is the same Botox that is used for wrinkles, but it has actual medical uses as well. And this is a procedure that only takes a minute or two and involves injections into the parotid glands here and the saliva glands here, often underneath the chin, and can be very effective at reducing drooling for as long as 3 months. Swallowing difficulty in Parkinson's disease is much more common in advanced Parkinson's, and treatment can be something as simple as eating more slowly and realizing that it's important not to rush meals. Speech therapy can be helpful with tricks such as a chin tuck, bringing your chin down towards your chest when you swallow. And sometimes a modified diet or even a feeding tube can be considered if the symptoms are severe. Now, another autonomic symptom relates to bladder and urinary function. And most commonly, this manifests as overactive bladder, so having to go more often or having to go in a big hurry when you have to go. There are a number of medicines that fit into the category of anticholinergics that can relax the bladder muscle. These are the 6 medicines listed here, the top 3 of which are available as generics. The bottom 3 are currently only available as brand names. And these need to be used with some caution because of some of the side effects that have already been mentioned, such as the possibility of dry mouth, dry eyes, constipation, or confusion. And these are particularly more likely with the medicine oxybutynin, which is ditropan. And so some of the other lower down the list options may be considered in place of that. In the last couple of years, there's also been a new medicine approved, which is called Mirbetriq or Mirabegron, which works in a totally different way. It still helps to relax the bladder, but it does it on a different receptor in the bladder, something called a beta-3 receptor. And this likely has fewer side effects, whether cognitive or any other sorts of side effects, than the medicines on the previous slide. Another treatment is desmopressin, which is DDAVP. And what this does is actually decrease urine production. This isn't something that we generally use during the day, but it can be very helpful at night, particularly if getting up numerous times during the evening to go to the bathroom is a problem. It can be taken either as a tablet or as a nasal spray. And one note of caution is not to drink excessive fluids, including water, during the night while on this medicine, because that can cause electrolyte problems. Again, botulinum toxins such as Botox can sometimes be helpful actually injected into the bladder, and this is something that would be performed by a urologist. Less common than overactive bladder is a neurogenic or floppy bladder, and I won't say much more about this other than sometimes a urologist is needed to help tell the difference between one and the other, and that can be important because the treatments are different. Now, sexual function in Parkinson's disease is often an under-talked about situation, and on the next slide, there are some medicines that can be helpful for erectile dysfunction, but obviously sexual function is a lot more than just an erection, and the difficulties in movement that can happen with Parkinson's disease are an issue, as well as the interpersonal dynamic between a caregiver and a person who receives that care. And so this is something that is a little beyond the scope of our talk here, but sometimes even seeing a sex therapist can be helpful to sort of bring the issues out into the open and talk about possible strategies that might be helpful for that. So the medicines that are helpful for erectile dysfunction include all the medicines listed here in the middle of the slide that advertise during Broncos games and playoff baseball. It's also important to be aware that other medicines can cause erectile dysfunction, so it's not necessarily just an effect of Parkinson's itself. Beta blockers like metoprolol that's used for heart rate and blood pressure can sometimes cause this problem. And then a number of antidepressants can also cause erectile dysfunction as well. And so that would be something to talk with your internist or primary care doctor about whether any adjustments can be made there. Besides these medicines, there are also some second-line treatments for erectile dysfunction, which again usually involve a urologist. Now, orthostatic hypotension in Parkinson's disease can be a fairly common problem, and this manifests usually as lightheadedness or dizziness, particularly when standing up out of a chair or getting up out of bed. And it's related to a drop in blood pressure or a pooling of blood in the legs, even just transiently related to a change in position. One of the first considerations here is to again reassess the need for antihypertensive medicines. Medicines that have been used for blood pressure for a long time may not be needed as a person goes through the course of Parkinson's disease. There are a number of non-pharmacologic options, including increasing salt and fluid intake, sometimes doing simple leg exercises like flexing your calf or thigh muscles before standing up can help get the blood closer up to the brain so that a person doesn't get lightheaded when they stand up. Compression stockings, you can see this person is having the typical extremely easy time of putting on compression stockings, but those can be helpful with reducing the amount of blood that pools in the legs with standing up. Eating frequent small meals can be helpful because it keeps blood from pooling in the stomach, something called postprandial hypotension. And then elevating the head of the bed can be important because when you stand up, you're then not going from quite as dramatic of a position change. There are also some prescription medicines that can be helpful for orthostatic hypotension. These include fludrocortisone and midodrine. I think of these as filling the tank and squeezing the tank. The Florinef helps your body to hold on to more salt and fluid so that there's more in the tank. And then the midodrine acts on squeezing the blood vessels so that blood pressure is raised in that way. There is a brand new treatment option available for orthostatic hypotension, and this is called droxidopa or Northera. This is a precursor to a chemical called norepinephrine, and this medicine was just approved in the United States this month. And so if people have tried a number of other options, this is now a new option that will also be available. Pyridostigmine or Mestinon, I had mentioned before, is something that could be helpful for constipation. It also can be helpful in orthostatic hypotension by increasing nerve signaling to the blood vessels and telling the blood vessels, okay, I'm about to stand up, this is when you need to tighten up so that I keep blood flowing up to my brain. Domperidone, I had mentioned, is something that can be useful for nausea, and that can also be helpful for orthostatic hypotension. One thing to be aware of is that any of these medicines can cause an excessively high blood pressure when lying down, what's called supine hypertension. And so this is again an area where elevating the head of the bed, maybe by as little as 6 inches with risers under the head of the bed, can reduce the risk of that higher blood pressure when lying down. So we'll move on to talking about pain and sensory symptoms in Parkinson's disease. It can be a variety of pains that people with Parkinson's disease experience. It can be muscle pains in the calves, in the neck, or in the back. Sometimes it's joint pains in the knees or in the shoulders, which is often due to rigidity or stiffness. And then there can be cramps, and even more so, dystonia. And dystonia is an imbalance of muscle contractions that leads to an abnormal position or posture of the muscles. One of the things that people with Parkinson's can sometimes have is a hitchhiker's toe, where their big toe has a tendency to stick up, sometimes even through the top of the shoe, and that can be a very painful condition. Treatments for pain in Parkinson's disease range from the common sense, everyday pain treatment options to more advanced treatments. So stretching, massage, and warm baths can be helpful. Over-the-counter pain medicines such as Tylenol or ibuprofen are sometimes enough. Sometimes more aggressive medicines such as nerve pain medicines with names like gabapentin and pregabalin can be helpful. If there is dystonia, such as this toe sticking up, then sometimes botulinum toxin injections can be helpful for that or for other types of dystonia. Narcotics should be avoided if at all possible for a couple of reasons. One is that they can cause dependency over time, and another is that they can worsen constipation, which we've already talked about as a possible big issue. So another factor to consider is to determine if there is a relationship between the timing of medicines and when pain happens. And the reason for this is that pain is often a wearing off phenomenon in Parkinson's. And Dr. Kurtz had talked a little bit about this as well, but often when people take their medicine, there's sort of a kicking in, and both motor and non-motor symptoms are alleviated. And then as the medicines begin to wear off, there can be both motor and non-motor symptoms that are worse, including pain, in addition to the more obvious symptoms such as tremor, stiffness, and walking problems. And so adjustments that can be helpful include increasing the dose at each interval, or increasing the frequency that medicines are taken, or sometimes the addition of longer-acting Parkinson medicines. So the last category to talk about is sleep as a non-motor symptom in Parkinson's disease. And one of the most common issues is insomnia. It's more often a problem with staying asleep than it is with falling asleep, although both can be issues. Medical treatment can include melatonin, which is the body's natural sleeping chemical and is available over the counter, and then some prescription medicines, such as clonazepam, which you'll hear me mention several times in the next few slides. Sometimes sedating antidepressants can be helpful, such as trazodone or Remeron. But there are also some medicines that should be avoided, and these include Benadryl, or basically anything that has PM in the name. A lot of people don't know that Tylenol PM or Advil PM are just Tylenol and Advil mixed with Benadryl. And so anything that is Benadryl can cause problems in people with Parkinson's disease. So there are some comments about non-medical treatment options, which are known as so-called sleep hygiene. This refers not to taking a shower before going to bed and trying to sleep, but to a number of behaviors that can be helpful with optimizing a person's chance of having restful sleep. Excessive daytime sleepiness is a related problem in Parkinson's disease. And the first thing to consider is that if there's insomnia, that treating that is likely to help with the sleepiness during the day. One of the simplest and often most effective treatments is naps, and if that's something that works with your schedule, then it has less possible side effects than a lot of the medicines that are listed here. Certain Parkinson medicines are more likely to cause sleepiness, including the dopamine agonists such as Requip and Mirapex, so sometimes an adjustment of medicines is necessary. Medicines that can, in their own right, be helpful with sleepiness in Parkinson's disease can include caffeine, medicines called modafinil and armodafinil, or some of these stimulant-type medicines such as methylphenidate and atomoxetine. Restless leg syndrome is a condition that's very common in the general population and even more common in people with Parkinson's disease. And this has been described in 100 different ways, but is basically any sort of uncomfortable feeling in the legs, generally worse at night, that's briefly relieved by movement. The treatment of restless legs, fortunately, often overlaps with the treatment of motor symptoms in Parkinson's. So medicines that are dopamine agonists, such as Mirapex, Requip, and Nupro, as well as Sinemet itself, can be helpful with this treatment of restless legs. Now, if restless legs is the main problem and a person is not already taking Sinemet, then this is often not a good reason to start Sinemet because it has a higher risk on its own of causing augmentation or a gradual worsening of restless legs symptoms. Other medicines that can be helpful include medicines that I've already mentioned in a couple of different contexts. Gabapentin, which can also be helpful for pain, clonazepam, which can also be helpful for sleep, and only if the symptoms are refractory to all other treatments, narcotics are sometimes considered. Periodic limb movement disorder is often confused with restless legs. Restless legs is the feeling of needing to move, but periodic limb movement disorder is when the legs move on their own. This more often happens when a person is asleep, and so a person might not even be aware that this is happening. But it's important to be aware of it because it can cause partial arousals throughout the night, and if a person is partially waking up without realizing it dozens or hundreds of times a night, then that will lead to an increase in sleepiness during the day. The treatments used for periodic limb movement disorder are similar, actually often the same as those used for restless legs. A more severe type of abnormal movements that can occur during sleep is what's called RBD, REM sleep behavior disorder. And these are more complicated movements that can occur while a person is actually asleep. This ranges from sleep talking to rolling out of bed to other more complicated movements, including possibly punching and kicking in the sleep, which can possibly put the bed partner at risk of being injured. And so some non-pharmacologic precautions, if RBD is severe, can include moving sharp things away from the bed, using bed rails, putting something soft next to the bed in case a person does fall out of bed, and if necessary, then even sleeping apart from the bed partner to reduce that risk of injury. This is something that fortunately tends to respond extremely well to treatment, and clonazepam, which I've mentioned before, tends to be very effective, and melatonin, which I mentioned as a sleep treatment, can also help the symptoms of RBD. In 2010, the American Academy of Neurology released official recommendations about the treatment of non-motor symptoms in Parkinson's, and it came down to a paltry 3 things, which is that Sinemet helps periodic limb movements, Miralax helps constipation, and Viagra helps erectile dysfunction. So we obviously in clinical practice know that there are things far beyond these that are helpful, but this is an area where the research is lagging in catching up with our clinical experience. It's also an area that we need more research in so that we can identify further effective treatments. So thank you for your attention. At this point, Dr. Kurtz and I will both be available to field questions. So thank you very much. So the question is about curling of the toes that sometimes happens with Parkinson's. Is that dystonia? And quite possibly, yes. And so although sometimes the toes stick up, they can also curl down. And so that is something that muscle relaxants and possibly even botulinum toxin injections might be helpful for. So the question is about, what about bloating as a possible gastrointestinal symptom in Parkinson's disease? And that, I would say, is certainly part of the same spectrum. Any sort of gastrointestinal discomfort can be an effect of Parkinson's itself or Parkinson's medicines. A lot of times constipation is tightly related to bloating, and bloating is often something that happens because a person is constipated. So starting there would be a place to start. And then some of those same medicines that can be helpful for nausea can also be helpful for bloating. The question is about melatonin. What dose? Can it be taken every night? I often recommend 3 milligrams as sort of an average dose, although I have some patients that take as much as 10. And it is a medicine that can be taken every night. I usually suggest taking it a couple of hours before bedtime. It's not a medicine that knocks you out so much as it helps prepare your body to go to sleep and stay asleep. So the question is, are there situations where melatonin should be avoided? Melatonin does slightly increase the risk of bleeding and bruising, and so if a person is on blood thinners or has a tendency towards bleeding, that's something to be cautious about. Autoimmune conditions, I'm not aware of any issues there.
Yeah, so typically with antidepressants, we're wanting to wait about 6 weeks to see the effect of a certain dose with antidepressants. So after that time, if it doesn't seem to be effective, then either increasing the dose of that medication or considering a different medication. But certainly giving it some time to take effect is necessary with antidepressants.
So the question is, are vision and hearing possibly involved in Parkinson's disease? Hearing, not that I'm aware of. I think that's more part of the aging process. But vision can definitely be impacted in Parkinson's, ranging from dry eyes to double vision to visual processing issues, where like some of the illusions and hallucinations that Dr. Kurtz had talked about. A lot of times seeing an ophthalmologist or even a neuro-ophthalmologist can be helpful in those situations.
So the question is, when is it time to start working with a psychiatrist? And that's really person dependent. You know, there are neurologists, there are primary care physicians who feel very comfortable using antidepressants, using antipsychotic medications, but a lot of times if the regimens become complicated, if there's difficulty managing symptoms after 1 or 2 different medications, then it's helpful to get the expertise of a psychiatrist.
The question is about, what about treating constipation that occurs as a side effect of Parkinson medicine? This is sort of a classic debate between patients and doctors where the doctors say, it's your Parkinson's, not your medicine, and the patient says, but I didn't have it until I started the medicine. So the treatments for the most part are the same as they are for constipation caused by the disease itself. The stool softeners like Cholase or Docosate, I think can be taken on a regular basis, even every day, without risk of dependency. But the laxatives like Miralax are probably the ones that have that warning about not to take more often than 7 days in a row without your doctor's recommendation. I would agree with that as much as possible, but there are occasionally cases of severe constipation where people do end up needing to use laxatives chronically. But some of the other medicines that are listed on that constipation slide might be used instead of those over-the-counter medicines.
So the question was about transcranial magnetic stimulation, and that's actually something that originally was studied in people who have depression, not in the Parkinson's population. So it's actually something that is used pretty commonly with psychiatric care to manage symptoms of depression already. So that is something that's been out there for quite some time. More recently, we're starting to see, since depression is such a big problem in Parkinson's, whether or not we can also use this safely in a Parkinson's population, and we still don't know enough to say yes or no, but there is some promise that it could be helpful. And I think the other thing is during my talk, I didn't really talk about what that actual treatment is because it does sound kind of scary. But with transcranial magnetic stimulation, what it is that you have a probe that goes over specific areas of the brain, and it's sending a magnetic signal that's affecting some of the nerve cells in the brain, not permanently injuring or permanently changing those cells, but causing a different activation in those cells. And that's how that technique works. It's a non-invasive type thing where people go into a clinic regularly, have a treatment for depression, then come back a week later and have another treatment. So the question is, what do movement disorder neurologists have different than a neurologist? And in general, all the treatments that we're going to be able to offer are the same as with a neurologist. For movement disorder trained specialists, it's something that we have a vast interest in working just with Parkinson's patients or very similar conditions, and we also get specialized training in it. So we've both gone through general neurology training, but then we stayed on additionally to work specifically with Parkinson's and learn more specifically the different aspects about treating Parkinson's disease. So that would be the main difference that I would think about.
Yeah, I would agree. Well, that's the end of our formal session. Dr. Kurtz and I will be up here for a while longer to answer questions individually. Thank you all for coming.